has recently been accepted into aesthetic plastic surgery about cryolipolysis for reduction of localized subcutaneous fat. It's a review of the literature and an evidence-based analysis. As you all probably know, cryolipolysis is a non-invasive approach based upon inherent sensitivity of adipocytes to cold injury. Now, with controlled cooling, selective destruction of fat cells can be achieved without damaging surrounding tissues and without significant change in serum lipids levels or liver function tests. There is evidence that adipose tissue is preferentially sensitive to cold injury, and studies actually suggest that temperatures as high as 1 degree can decrease adipocytes' viability. And FDA clearance of the technology was obtained in 2010 and 2012 for fat reduction on the flanks and the abdomen. If you look at the latest systematic reviews, they claim that reduction in the adipose layer may approach 30% per treated region. But now keep this number in mind. However, it is not clear whether available evidence to date about its efficacy justifies the extensive and widespread application by many practitioners without a well-defined indication or objectives of treatment. In order to better evaluate this, a systematic search of PubMed and Scopus computerized medical bibliographic database was conducted with the search terms cryolipolysis, defined cryolysis, and cool sculpting. We found 173 publications, 34 reports matched the inclusion criteria of this review. 5 experimental studies were identified and included in this review to further supplement the discussion. Now, the safety of cryolipolysis and its efficacy have been claimed in numerous clinical reports and case series. However, most suffer from serious methodological flaws, such as non-randomization with no comparator groups. And most of these reports fall short of setting clear treatment objectives besides reducing subcutaneous fat layer in the targeted areas, and they certainly did not consider the standard of care to which any new body sculpturing modality must be compared. Another flaw was that many authors are also clinical advisors or sponsored by cryolipolysis equipment manufacturers, which is an obvious source of conflict of interest and certainly bias. Now, if we also want to look at the scientific evidence, very little evidence about the efficacy of cryolipolysis has been provided, and important links of the mode of action and the physiological changes that may lead to fat reduction are still not yet fully understood. Now, 2 main mechanisms have been proposed, in fact. One of them is selective acute heat extraction, which induces panniculitis with subsequent apoptosis. The other is thermogenic fat metabolism without cell disruption. And if we want to look more into the science and the physics, fat cooling takes time actually, and more than 3 minutes are needed for superficial fat to reach 10 degrees at the dermis-fat interface. And the temperature drop in deeper subcutaneous layers is not very consistent, and the reduction in thickness of these layers is not to be expected. This is a randomized controlled trial by Folster et al. It has a blinded assessor and a well-controlled methodology of cryolipolysis application and outcome measurement. In this particular study, the adipose layer thickness was evaluated in both the study and the control groups 15 days prior to cryolipolysis application, and then upon follow-up at 30, 60, and 90 days thereafter. The investigators could not demonstrate any significant difference between the 2 groups, and the high level of evidence of this well-conducted study should seriously question the current practices. And the conclusion of this article states that a single session of the cryolipolysis with the protocol used was not effective for reducing the adipose layer thickness after 30, 60, and 90 days. And also, the majority of the healthy women were not satisfied since the treatment did not show an improvement in fat thickness. And cryolipolysis caused pain and some adverse effects, such as change in sensitivity, bruises, petechia, edema, and itchiness that were quickly resolved. So, what are the flaws in reporting of outcomes? The reporting of cryolipolysis clinical outcomes has been primarily assessed by means of circumference measurements, caliper measurements, ultrasound, patient satisfaction questionnaires, and observer impressions. And all of these are subject to bias. And currently, there are no objective, non-invasive, quantitative, reliable, and practical techniques to measure changes in the subcutaneous fat layer. But 3D imaging to analyze volume reduction independently of observer impression and patient satisfaction scores is a newly introduced tool that could bring some objectivity to outcome measurements, even though it does not totally eliminate operator error. Its utilization, however, is still very limited. Now, the best optimistic reports about cryolipolysis do not claim more than 21% favorable outcomes. And regardless of the significance and validity of reporting results as a percentage improvement, when we examine the actual reduction in thickness, cost to benefit value of a method that actually reduces fat thickness by 2.5 millimeters in 4 months should raise serious questions. The Caruthers reported close to 3 millimeter fat layer reduction in the upper arms. Zalixon also did the same on the inner thighs, and there's also a report about submental fat layer reduction of 2 millimeters. Now, it's difficult to imagine how clinically significant 3D body sculpturing that requires fat removal from deep and superficial layers and from confluent areas could be achieved with such minimal changes in the superficial subcutaneous fat layer that would only become evident 3 months after treatment. Now take a look at this picture. Despite somewhat obvious fat reduction, aesthetic results reported in publications are mostly suboptimal, and in some patients they are frankly objectionable. Here's another example of a study that shows suboptimal aesthetic results after cool sculpture. And again, although you see a change, but also it's a suboptimal aesthetic result. And again here for submental fat reduction. And here for gynecomastia, you can see the same. And also again. Now, as you can see from all these studies, it should be mentioned that numerous cryolipolysis equipments are available from different manufacturers, and all these have various applicators and application protocols. The first fact I like to point out is that till today, there is no consensus in the literature regarding the most appropriate equipment and the ideal cryolipolysis treatment protocol regarding the parameters of the device, the periodicity, and the number of sessions required per body region. And also keep in mind that it's still not clear what is the patient's BMI range for which a reasonably favorable outcome may be expected with this technology. But definitely, as conceded by Sasaki et al., cryolipolysis does not match liposuction, which remains the gold standard for body sculpturing and to which other modalities should always be compared. But we should also look at the advantages of these technologies. The good safety profile is one of the advantages of non-invasive cryolipolysis, but it's still not painless and it's not entirely without any risks. Now, besides disappointing asymmetrical or unfavorable results, serious skin necrosis, although rare, has been reported. You can also have redness, bruising, discomfort, and temporary numbness. Nodules can also occur, but also we must always tell the patients that paradoxical adipose hyperplasia is another complication which is most commonly reported in men. Here's the patient which is described in an article which is showing on follow-up after 3 months nodular infiltration and the irregularities which can happen. Now, another advertised perk of this technology is its skin tightening effect. Now, Cryolipolysis has not been recognized as a skin tightening procedure, and skin adherence to new body contour and firmness has been observed in patients with previous flaccidity, and it occurs in a verifiable way, according to some authors, in almost a quarter of the cases. But it's still not known how predictable this skin tightening effect can be, and it's not known also how it may be affected by the patient's age, the skin condition, as well as the BMI. Now, there is no need to argue whether cryolipolysis induces adipocyte apoptosis and cellular death or not, and how much fat tissue layer can be reduced. But in the final analysis, the main concern should be how effective this treatment modality is in meeting the patient's expectations and in producing a harmonious, aesthetically pleasing outcome. So instead of attracting patients with the non-invasive nature of the modality and the hypothetical expected percentage reduction in circumference or in the fat layer thickness, which may be irrelevant if not actually misleading, the patients should be allowed to decide and be able to make an informed consent based on solid evidence which is provided by controlled, blinded clinical studies about body sculpturing outcome with cryolipolysis, and that should be compared to that of liposuction, which is still the gold standard for body contouring. Now, to claim that cryolipolysis is a non-invasive technique that could be a good alternative to liposuction in patients with moderate fat excess, as claimed by some, is certainly not justified. And further research should be encouraged to prove with good methodological rigor positive effects of this treatment modality, and it should determine the categories of patients in whom the most favorable outcomes might be expected. And we must keep in mind, however, that mere fat layer reduction is not and should not be the main goal of any body contouring modality. It's rather achieving a 3D harmonious body shape to our satisfaction as well as to that of the patients. Thank you.
Next talk will be a very interesting topic about methods of training for rhinoplasty, the feedback and the outcome and the financial burden. Dr. Rami Fadul will be giving us this lecture.
Hello, my friends. My name is Romeu Fadul. I'm a Brazilian plastic surgeon from São Paulo, Brazil. And I would like to thank you very much from the organization committee, Dr. Mohamed Abuzaid and Dr. Ayus Saudi. Thank you very much again for this kind opportunity to participate of ICC. Today I will present my lecture as the methods of rhinoplasty training and financial feedback. I have no conflicts of interest, no disclosure. For rhinoplasty training, the rhinoplasty is a complex surgical procedure with a steep learning curve and a small margin of error. So when do it right at the first time, it's a usual phrase that we usually heard with older surgeons. The training options in rhinoplasties are during residence animals such as sheep, dolls, or nasal silicone training model, fresh and frozen cadavers, or fellowship programs when you travel to another country or another city and training like fellowship or observer fellowship. So anatomically accurate rhinoplasty training module would provide an excellent tool for both the new and the experienced surgical alike. We'll present comparing cost benefits of different methods of learning rhinoplasties in Brazil. So in United States, the rhinoplasty is the third most usual cosmetic surgery procedure, but This surgery followed 44% of volume comparing to 2000. In 2000 we have this number, and in 2018 it's going down to 230,078 cases. There's a report in 2015, but in Brazil the rhinoplasty is the fourth most usual cosmetic surgery procedure, but it's growing up about 142% of volume in the past 7 years. It grew like these numbers. In 2018 we have approximately 108,000 procedures of rhinoplasties. The ratio between plastic surgeons for habitant in Brazil is 1 for 42,000, and in United States is one surgeon for 50,000 habitants in United States. New plastic surgeons per year in Brazil, we have 245 new plastic surgeons per year, but in the United States we have about 204 new plastic surgeons per year. And the total number of plastic surgeons in Brazil, we have 6,097 in 2018, and in USA we have 7,255 in 2018. Which are the options of training rhinoplasties in all programs? We're having the residence, usually the third year residents training this kind of surgery. In animals, models like sheep or rabbits, in medical dolls with nasal silicone training models. We have the software 3D virtual reality, but we never train in a real patient or a real animal. And we have the cadaver lab, the hands-on fresh or frozen or formalized cadaver that I think is the best option for training residents, fellowship, or older surgeons. We have also the fellowship programs in rhinoplasty services in all over the world. Even in Brazil, we have many of these fellowship programs. We are going to explain each one of them. The medical dolls and nasal silicone training models. We have three models. One, the total head silicone doll. It's not specific for rhinoplasties. The second, it is nasal multipart silicone model, that the upper and lower lateral cartilage. We have the septum, including mucoperichondrial lining, and overlying exterior skin were manufactured using varying types of medical grade silicone. That imported and edited in mimics produce a 3D reading of the area. And the third one is the silicone solid block, even is not specific for rhinoplasty. Here we have the second model, is the nasal multipart silicone model that we can do separate the skin from the osteocartilaginous skeleton, and then we can train rhinoplasty in this model. The cost for professional is about $480 to $2,050. Is the main price in Brazil. Silicone doll full is about $7,200. The main time curve, the learning curve, is median. We will learn this kind of surgery in months if we repeat minimum twice or 3 times. Advantage, we have a hands-on training, anatomically correct, design specific for learning techniques in rhinoplasty. We have the relaxing training models, no blood, no real patient. We are more relaxing time. Mistakes to learn. We can do mistakes to learn in this kind of models, in medical dolls or nasal silicone training models, but some disadvantages. It's not human tissue, no comparable structures. Simulate mucosal lining of cartilaginous septum, it's impossible. It's a so thin structure you cannot simulate it. So it's more difficult to simulate this lining cartilaginous septus. This is only worse surgery per model. Then you drop to the trash and you must use another silicone, nasal silicone training model, and it costs about $2,000 each. Some experience for secondary rhinoplasty. You cannot train secondary rhinoplasty in this kind of models. Investment return is about 1 to 2 surgeries. It means a surgeon must do 1 to 2 surgeries to return the investment he did in this kind of training. It's more confident for surgery at private clinic or HC insurance. Then you have more patient. If you are more confident for surgery, you have more patient always. Animal model. We have the sheep, the rabbits, and the monkeys. It's so hard to use monkeys in Latin America. The cost for professional is about 800 to 3,200 for rhinoplasty training period. So the main time, the learning curve, it's high. There is no comparison to human nose. Advantage, expert monitor discussion. You can discuss with your monitor many different techniques and how to do, and because it's an animal model. Best for training undermining and sutures. It's the best model for training suture and undermining and separate the skin from the osteocartilaginous skeleton. You can repeat many times if easy to obtain the animals. If you can have monkeys, it's very hard, but it's really nice to train in monkeys. It's good to stimulate medical students and residents. It's like phase 2 study. Then you go to phase 3, is the clinical step. Disadvantage, it's hard to find because we have the animal protection foundations. Similar but not equal. Nasal human structure are unique. No experience for secondary rhinoplasty. You cannot have any experience for secondary rhinoplasties. Investment returns its years. You must invest many years to have any return. More confidence for the next step training models. You can be more confidence for the next step, that is training in cadaver lab. We do not believe that this model exclusively could well-trained surgeons for rhinoplasties. Medical residence in plastic surgery is based on 3 main components: surgical, scientific, and interprofessional formation. The concern between the coordinators and the teachers is that practical surgical education is enough for professional qualification. The foundation of surgical anatomy, physiology, pathology, and other basic science is fundamental to plastic surgery. The Brazilian Society of Plastic Surgery, you have 86 plastic surgeon residence training programs. It's been necessary 6 years of medical formation, 2 years of residence in general surgery, and 3 years in plastic surgery. In most of the training programs, rhinoplasty is for residents at the 3rd year. Rhinoplasties, all 3rd year residents do training in rhinoplasty in Brazil, but usually they do only 4 training rhinoplasties, the main number in all 86 residence training programs in our country. In the United States, we have 14 training rhinoplasties in the third year residence in residence in the third years. So surgical residents often do not exposed to sufficient case nor given adequate time in residence to acquire skills for highly complex procedures. Ample evidence regarding the disaffection of many surgeons with their level of training. A case can be made for such gaps persisting in most areas of surgical training. Students similarly face a shorter and rapidly changing surgical clerkship characterized by anecdotal learning and a step curve of performance. Cost for professional is zero. No residents pay for it. Mean time learning curve is median. It's about 2 to 3 years. Advantage: we can have the expert monitor orientation. We can select case for better learning. We have patients that belongs to services. Partially, it's a partial responsibility. The patient not belongs to the resident or to that physician, belongs to the plastic surgery service of resident. Previous and post discussion with colleagues and monitors. All the residents discuss these cases with the monitors and his other colleagues, and then he can learn more. Disadvantage: fear, anatomy and inexperience, and etc. etc. All residents program, the resident has more fear to do this kind of surgery because it's so delicate. Patient complications and defects. If any hard manipulation, we can have defect or complication, and the resident can be simulated to do not another rhinoplasty like that. Resident not follow patient for more than 1 year, so you cannot follow that patient more than 1 year. No experience for secondary rhinoplasties. Usually they do only primary rhinoplasties. And SU, third most the most common SU country in the world for plastic surgery and especially for rhinoplasties. Investment return. Main price in Brazil for a rhinoplasty is $1.7 thousand. Surgeries at private clinics or healthcare insurance. Facial aesthetic procedures, including rhinoplasty and facelift, remain challenged to the residents in our country. Fellowship programs. Fellowship in plastic surgery have 1 to 3 years post-final resident program. It's best theoretical learning, time to research, read, discussion and meetings. Usually no practical training, observer model, local medical regulations, etc. etc. University, usually you do in university or private clinic or public hospitals. Most of the program is not specific, not only rhinoplasties, hair subspecialties. The length of these fellowship programs can be from weeks to months. No working, other city or country, away from your family. It's really difficult times, but only you can see observer, you cannot touch the patient. Most of the best plastic surgeons accept fellowship students. Cost for professional, weeks to months without working, plus fees, plus hotel, plus food, and etc. etc. Mean time learning curve is median, months to years. Returning home to begin surgeries and test on patients to technique that he or she saw in his fellowship. Advantage: expert professional orientation, follow patient and post-op period, day by day of a good professional, learning not only rhinoplasties, share personal experience, more confidence, and treat complication or defects. Disadvantages: fear, anatomy, inexperience, etc., 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 and no fear, excess of confidence after fellowship. No testing procedure for rhinoplasties, must take all tips and learning techniques to home. There is no testing after fellowship. And ensue, most of them occurs 3 to 8 years of professional activities, especially in rhinoplasties. Investment return 1 to 3 years. Surgeries at private clinic or healthcare insurance. And the cadaver lab is a human tissue, is complex, no substitute for real thing when training for complex procedures. Many advantages in plastic surgery are a direct result of using cadaver as a learning tool. Face transplantation, like NIU Dr. Eduardo Rodrigues, bilateral hand transplantation, the Children's Hospital in Philadelphia, and with cadaver lab, with simulation models of plastic surgery procedures has been developed, incomparable to the dissection of fresh tissue. Training aesthetic and reconstructive procedures, many courses in all over the world, like we can see here in the Journal of ISAPS in January to April 2016, how cadavers are changing plastic surgery outcomes. So the cost for professional from $750 to $3,500 each lecture. Meaning time learning curve is low, it's about weeks to months. Advantage: expert monitor orientation, real human tissue, errors will be welcome. Do it again procedures. No bleeding, easily recognizable structures, 3 to 5 hours each lectures in São Paulo, Brazil, and secondary rhinoplasty procedure is possible to train. Disadvantages: fear again. Anatomy, you must know anatomy, so you must repeat the procedure 1, 2, or 3 times, and inexperience. Post-operative period is not possible. And physiological scarring events, scar, healing, contraction, and retraction, we cannot see. Returning investment 1 to 2 surgeries, money back return. More confidence in those surgeries and better results, and you have more patients. This is our training model in cadaver lab in São Paulo, Brazil. It's just like a surgical room with surgical clothing and fields. We see the anatomy, the nasal anatomy, like here we see the osteoskeleton cartilage, the open rhinoplasty procedure. Is we see the nasal anatomy and graft procedures, like we see in the bottom right. All the details, we can dissect this mass to see how thick is this mass of the patients, and then again this mass, this mass of the nose, and then under this mass we see the osteocartilaginous skeleton, and then the step-by-step incision, undermining, and then exposure the osteocartilaginosis skeleton, and then the grafting procedures. We're training all the grafting procedures like we see here, the strut grafting, like to remove the septal grafting, cartilage grafting. Here we train all these steps like we can see here. Then we split to do the different kind of cartilaginous grafting. The ear grafting procedure, we always training this kind of procedure in our cadaver lab training module. Spring suture to avoid the spreader graft. And we train the costal cartilage graft. We remove from 2 to 6 cartilage graft both sides, and then we split. Here is the second right cartilage graft, fourth, sixth right, and then we split. And then we rest in saline solution, 0.9%, 24 degrees Celsius for about 30 minutes to see how they curve. And then we see here from the evolution 5 minutes, 15 minutes, and 30 minutes how they curve. So we have different types of noses. We must train in African American noses, Middle East, Asian, and Caucasian, and others. We should train all of kinds of these nose surgeries in the cadaver labs. Rhinoplasty meeting and courses, we did all. In Amsterdam, we have cadaver labs, Chicago, Dallas Rhinoplasty, Miami Mark, Mid-Court Nevada, New Orleans, Italy, Belgium, and China. All of them we have cadaver lab training models. There is a significant difference on the sacked cadaver, formalized, frozen, and fresh cadavers. We always use in Brazil, in São Paulo, Brazil, fresh cadavers. So we have a 3.5 hours per lecture, 1 student per cadaver, with monitor direct supervision, 3 levels, basic, advanced, and complexes. This is only in São Paulo, Brazil. In no other place I went in my life I see this kind of teaching model. So we have pictures and films are welcome. We can do it in Portuguese or English, and we also do training for facial paralysis, flaps, and other kind of surgeries. So in conclusion, combining training programs is the best option for us for training rhinoplasties. Residencies plus silicone modules plus cadaver lab is the best investment return. The fellowships for more experience improve surgical techniques from different surgeons. Animal mod is a good option to train basic surgery, not good for rhinoplasty. Thank you very much. And if you have any kind of ask, please send me email. I will be pleasure to send you answers. Thank you very much.
Next talk, we'll have Dr. Romeo Fadul talking about a very interesting subject, which is medical rhinoplasty, non-surgical rhinoplasty.
Dear friends and colleagues, I'm happy to be virtual with you this ICC 2020. Unfortunately, due to COVID-19, I'm not able to come to Cairo, and I hope to see you next year, 2021, in Cairo for the next ICC session. And I'll present for you today the art of medical rhinoplasty, give you the indication and the limitation of this technique. Slide, please. Please, I have no disclosure, but please do not take photos or records. Thank you very much. Slide. The mentality and the approach to the nose job changed a lot. So Fanny Brice was a famous actress in the 1920s, 30s. And at that time, when she came in front of the camera after rhinoplasty, a lot of people screamed and said why she changed her Jewish nose. It was a crime at that time to do a nose job. But Barbara Streisand, also Jewish, came in '68 with Omar Sharif in this movie, and a lot of the kiss, and during the kiss, and a lot of people said, why God did she not do a nose job? So the mentality has changed a lot in a couple of years in Hollywood and also all around the world. Slide, please. And step by step, we saw a lot of catastrophic results, especially we have Michael Jackson results. With imperfection coming to necrosis and to really dramatic problems. The reason is why, please slide. The reason is that the nose is very complex. You need to know very well the anatomy, the functional and the aesthetic anatomy. You have to have a good experience. There is not a surgical technique, but a lot of surgical techniques and a lot of indications, and you have to adapt to each face and to each nose. And that's why came the medical alternative with the injectables, but this medical alternative is also now performed by non-plastic surgeons. So even if you're a doctor or dermatologist or whatever, you have to know very well the nose before injection. And knowing the anatomy slide is not enough. You have to be an art. You have to know, you have to be also, you have to be artists also, and you have to know exactly the dimensions and the proportions of the nose on the face. Slide. Because you can not only treat the nose, and you'll see later in some slides that treating the nose alone will not give you good results. Slide. You have to know the right angles, how to restore the nasolabial and the nasofrontal angle, and also how to restore the light lines that give you this beautiful result. Slide also. Muscles are very important to know and to understand if you're going to treat the dynamic nose. This is an example slide of how to treat nostril with just some toxin. Don't do this if you're not able to know exactly where to inject and how to do it. But this patient is not really ready for a nose job, and with small units of toxin we can change her nostril during the aspiration and expiration. Slide. So for the dynamic nose I use some Botox and Dysport, and for the static nose I only use lift. I have no actually disclosure with Galderma, but I will tell you why I use lift now. It was Berlin before, but now is lift. Slide. Because of this slide. Look at here this Ristilla lift slide. You see that the rheology slide here is more important with the lift. So I need something that will not move. I need something to sculpt the nose, and I cannot use other injectables because they're gonna move with time. If you put your sunglasses, it's gonna move. If you put with the time also, I need something that may stay at least for 1 year, and lift is very good for this indication. Slide. Medical treatments. So the injection technique, why I'm using only needle, I'll tell you. I don't use cannula. Cannula is for people who are a little bit afraid to treat the nose. The best, if you're a surgeon, I need a surgical approach, and needle is the best for a millimetric approach. I'm always deep. You have to be always deep. You have to feel the bone. You have to feel the cartilage. Otherwise, don't do it. And always go with a few cc's. Aspirate always before. And I have no vascular complication for more than 200 noses injected. Slide. This is mine. This is my lift, and this is an aspiration during a session of injections. You see, it's very, very, very dangerous. I hopefully aspirate before, because if you inject and you will have big necrosis. So I aspirate and I have this, I stop. Slide. This is the patient the accident happened with. So you see, she came to me after a nose job, and we did it, this is her after 1 month, but after just the aspiration, look at what happened. And I did not inject, but I know that I have some hyaluronic acid, slide, and this happened, but without, thanks God, any necrosis. You see that the result after 1 month is stable, no necrosis. So you have to aspirate if you're going to go with a needle. Slide to avoid this kind of catastrophic and dramatic necrosis. Slide. So, first of all, let's see what happened. The problem is that the nose is a distal vascularization. It means that there is no really anastomosis. So you have to know where exactly to inject, and you have to know where is your lateral nasal artery, where is your dorsal nasal artery, and where is your angular artery. You have to know the other branches and to avoid them. By being deep in the right plane, you're gonna avoid them. Slide. And this is a very interesting paper published in APS in 2017 by Tansatit, proving that there is an injury mechanism of the dorsal nasal artery that will occur with the cannula if you will going from the infratip to the radix and encounters a bony dorsal hump. The cannula misses the periosteal plane to the subcutaneous plane when the dorsal artery crosses the midline. So if you're gonna use a cannula, so better to re-enter in the middle of part to minimize ocular complications. This is very important because, slide, we saw that with cannula you can also do arterial perforation. So cannula will not help you to avoid 100% the problems. So what will help you to avoid the problems is that the good knowledge and good practice, good knowledge of the anatomy and good practice of nose job. I think that doing the nose is for people who already do surgical noses, honestly, to be very comfortable. Otherwise, you will not have a very, very good result. But you can start slowly, and by knowing better this area, you can be comfortable then. Slide. So there is no functional indication. There's only aesthetic indication. If she is not breathing well, this is a septal problem. So this is not a good indication for the injectables. So can we treat large noses? Can we treat all the humps? Can we treat deviated noses? And can we treat people who already did rhinoplasty? Slide. This is a good indication for medical rhinoplasty, but she wants a permanent result, so I did a surgical approach for her. And, slide, this is a good indication for surgical rhinoplasty, but she's not ready for the surgery, and I performed a 1 cc injection for her. You see that it's pretty the same case, but we have two results, one surgical and one medical. Slide. This is the same patient, and you saw here how we restored the light lines, the sheen lines, the aesthetic lines. Slide. This patient came to me to have injections for the tip, and I told her that she's a good indication for a rhinoplasty, but she's not ready. We did this. But honestly, I'm not really happy, because if you want a finesse and the result, and then the best way to do it is a surgical slide. And you see that this patient, after a nose job, the finesse is here, and the results is much better than injectables. Slide. So the good indications are patients who are not ready for the surgery. A dorsal hump can be a good indication, but be careful. I'll tell you how to inject it. The sagittal deviation without functional problems, a closed nasolabial angle, an open frontonasal angle with undefined radix, and for a revision rhinoplasty, yes. Slide. The bad indications are large noses, and big humps. Sagittal deviations with functional problems, open nasolabial angle and closed frontonasal angle with important radix definition, or multi-revision rhinoplasty, they are very difficult to inject. Slide. Let's come here to cases and see how we correct it. Deviated noses, slide. This patient came to me for injection, but she has a functional problem. Then a septoplasty and a rhinoplasty and the surgical approach is better for her. And this is what we did. Slide. This another problem of functional problem. So we did a rhinoplasty for her and a septoplasty. So functional problems, this is a good indication for surgical approach. Slide. But you see that this deviation is here without any functional problem. So I inject a half syringe and look at this, the result is here. Slide. For the tip and supratip, if the patient will come, slide, if the patient will come with a nose like this, you cannot inject her to have a better definition. But this patient, after 1 year of a rhinoplasty, she's very happy with her tip. Slide. Here we injected 0.2 cc in the nasolabial, nasal spine in order to open the angle. And I inject the tip with the supratip if the dorsum is correct, or inject the whole nose if you want to correct also a hump. This is it. You have to inject the whole nose to have a right, a nice shape at the end. Slide. This is an example how we sculpt the nose again without a definition before. And now we have the angles and we restore the supra tip break, and the result is much better. Very difficult case that she will need, slide here, a revision, but she's not ready and injected her petangulating. Look at the result. Slide. The dorsal hump is the most easy indication for the medical injection. So inject before and after the hump, and not always injecting the radix. Before and after the hump, and don't forget the nasal spine to have a nice shape at the end. Dear friends and colleagues, the layers you're not used to. This is another patient after rhinoplasty. We corrected by injecting the whole nose here with 1 cc of lift. Another patient here, we corrected the chin lines, and we corrected the columella, we corrected the tip, the separate tip, and you see that slide, the result here is much better defined. Another very difficult case, slide, operated 6 times, and with the other colleagues, of course, and came to me for revision with injectables. And I gave her 1 cc, and you see the result after 1 cc slide, and this is the result after 1 cc also. Slide. So don't focus only on the nose, and you have to hurry. This is the example for prophylloplasty. I usually inject the nose with the lift. I take kiss for the lips or do there, and I inject lift also on the chin. And you see the result. I will also inject it here. The eyebrows also are injected. And another case, slide injection of the nose, of the lips, and of the chin. You see how the prophylloplasty is performed using these 3 type of syringes. Slide. Another case here, we use 5 type of syringes to do the contour and to do the chin also. We injected the lips, we injected the nose, we injected the cheeks, we injected the eyebrows. And you see that the result is here. Slide. This is an example of the patient after rhinoplasty. You see that we injected the nose and we injected the chin a little bit, but especially the nose. You see that it's tricky here, and the result is very, very natural and smooth. Slide. Another example, how to inject the nodes in the chain at the same time. You see that advancement of the chain and
Hello, can you hear me? Hello?
Hello.
Hello, can you hear me?
Yes, I can hear you. It's all clear, loud and clear.
Okay. Hello, Fadel.
How are you, Professor Romeo? How are you doing?
Good. Nice to see you.
Hello.
You again.
Hello, Dina.
Hello, good afternoon, dear professors. Thank you for your very valuable lectures, dear friends of the ICC. Thank you for your contributions. I would like to start with Professor Dr. Bishara Ateya, Clinical Professor of Plastic and Reconstructive Surgery at American University of Beirut. Thank you for a very nice talk about applications of HIFO in body contouring. You mentioned that some of the patients may need to do surgical liposuction following some sessions of HIFO. So, what do you suggest to do during the sessions of HIFO to prevent having complications that would interfere with surgical liposuctions, like having too much fibrosis that may cause irregularities with operative liposuction, such as having destruction or injury to the blood vessels of the skin. This may cause vascular complications with surgical liposuction following HIFO applications. What are your suggestions, please?
Hello, sir. It's an honor to be with you today. Hello, Professor Fadul. It's great to see you again. Thank you, everyone, for attending the conference. First of all, that's a good question. But the main point is, whenever patients are seeking non-surgical measures, typically they are not looking for surgical interventions down the road, at least not in the immediate future. And this is what's appealing to patients. It's not that we should not think about non-invasive measures as a transition towards a surgical intervention. We cannot really tailor the treatment at the moment to minimize the complications that can happen with regards to surgical intervention later on. But what we can do is counsel the patients about what to expect with such treatments, not only the complications, but also realistic results that can be achieved with such a technology. And this is the main thing that needs to be emphasized. Eventually, with the parameters of the device that are being used, another thing that's important to address is clear patient selection. We have to choose patients who are ideal candidates for non-surgical interventions. So if a patient would be better served with a surgical procedure, and we explain this to the patient, he would not go for a non-surgical procedure if in his mindset he's willing to go for something surgical. And that's the main thing that we need to emphasize and we need to keep it in mind.
Thank you for clarifying your points, Professor Fadel Shaheen, plastic and reconstructive surgery consultant at Trade Hospital and Medical Center of Beirut in Lebanon. Now moving to the next session about cryolipolysis. I will be asking you my questions, please. So thank you for a very clarified lecture, and thank you for highlighting the fact that cryolipolysis cannot be an alternative for surgery, because many of the doctors, especially of the young generations, would think that it may be an alternative. Thank you for highlighting and clarifying this fact. And
It's actually quite
yes.
appealing as a non-surgical alternative, but as it was mentioned during the lecture, there are so many devices on the market, there are many different protocols which are not standardized, and this varies from one manufacturer to the other. And the purpose of this paper was to clarify the point that as plastic surgeons, we need to always look for the evidence. In one lecture at some point, it was pointed out that in plastic surgery, we don't usually follow the evidence. It's usually experience and observations that lead to a certain intervention, and then we have evidence which comes up and we can make up our minds. But what we need to keep in mind is we don't want to harm patients. We want to provide a safe procedure for them. And above all, we need to make sure that the outcome of the procedure is very clear and patients have realistic expectations.
Yes, thank you for highlighting this fact. Okay, Professor Mohammed Abu Zaid would like to have a question for you.
Hello, how are you? Thank you for your nice presentations. I may ask you a question regarding the concept of the cryolipolysis itself. What about the blood vessels and lymphatics during the cryotherapy treatment? As you know, you are supposed to put the fat cells under the programmed apoptosis to act properly. So this is a programmed cell. What about the blood vessels and lymphatics, and what about the endotoxins resulting from this fat cell destruction?
Thank you for a very good question, Professor. Actually, if we want to talk about the mechanism of cryolipolysis, at the moment there are two theories, as it was mentioned. The first one, it's induction of cryolipolysis, which ultimately results in apoptosis or programmed cell death. The other mechanism would actually be thrombogenic, or actually to speed up the metabolism of adipose tissue. And this is through a different pathway, not necessarily through apoptosis. Of course, blood vessels would be affected. This is one of the reasons why we have bruising and sometimes ecchymosis and bleeding as a complication through this procedure. And there is no doubt that such low temperature will have an effect not only on fat cells, which are particularly at risk, but also on all the surrounding tissues. And one of them would definitely be, as a system, the lymphatic system. But I don't believe there are any studies at the moment looking at the effect of cryolipolysis on the lymphatic system, or at least I'm not quite familiar or acquainted with such studies to say, to be honest.
I have another question, please. You mentioned that some of the studies mentioned some decrease in the circumference of the abdomen following application of HIFO, and some others mentioned the paradoxical increase in the measures. In these studies, did they measure other parts of the body? Maybe the patient increased the caloric intake in the diet or decreased the caloric intake in the diet, and that's not the effect of the HIFO, or they were specific about that and they measured other parts of the body.
That's also a great question. To be honest, one of the downfalls of all the studies is that with regards to HIFO or cryolipolysis, the end result or the final outcome is not attained until weeks or even months later. During that stage, we cannot judge for sure whether patients have had any alterations in their lifestyle, in their caloric intake, in their exercise habits. We cannot really estimate it for sure. And definitely when someone is given a boost whether as HIFU or cryolipolysis, it might stimulate a change in their lifestyle. And it's a confounding variable, actually. And this is one of the points that we raised in our paper.
Yes. Thank you. Thank you, Dr. Shaheen. Now moving to our next renowned speaker, Professor Romeo Fadul, Medical Director at Cirurgica Plastino in Brazil. Yes.
Hello, how are you, Romeo?
Hello, nice to see you again, Professor Mohammed Abu Zaid. Thank you very much for this kind invitation. And
we miss you so much. We miss you so much, and hope we meet again in person. Of course, together with all our international speakers. And now with Dr. Thank you, sir. Now with Professor Dr. Dina Badawi for the questions.
Professor Dr. Romeo, a dear friend to the ICC, nice to see you. Thank you for your nice lecture about ways to train young doctors for rhinoplasty. It was very informative, and as for me personally, I'm really interested in this course in Sao Paulo. What I'm asking about, what do you think of the importance of adding a part to teach the doctors how to assess the patient psychologically and the patient desires? I mean, you may have a perfectly done rhinoplasty, but not a perfectly satisfied patient. And assessing the patient needs and assessing the patient response post-operatively, I think, and maybe my colleagues also would agree with me, that it is as important as assessing the patient intraoperatively. How do you think we can add this, implying this with the young doctors who want to have some training for their rhinoplasty?
First of all, I would like to thank you very much for the organization committee for this kind invitation. Thank you, Professor Mohammed Abu Zaid. Thank you, Dina, for this kind asking you made to me. Listen, the rhinoplasty, all the rhinoplasty surgeries is very important to train before. I think, you know, when you see a person, a patient or a colleague, anyone, the first thing you see is the eyes and the nose. And then you go to the mouth. So it's very important to train all the plastic surgeons, the beginners, in the resident programs, in the cadaver lab, to really know how to do the steps, all the steps of all kinds of rhinoplasties, closed and open. Doesn't matter. You need to train them. Because after the resident program, all of us, we will be plastic surgeons. So after if you do not train your resident in the programs, in rhinoplasties, after the finish the residence program, they will be like us. They all will be plastic surgeons. But, you know, some of them had trained rhinoplasties in cadaver lab, so they will be good. Remember, we trained in Cairo, Egypt 2 times, and, you know, they are really, they really want to be at the cadaver lab. So the most important thing, before any kind of patient, treat any kind of patients, do first the training in the cadaver lab, or maybe sometimes we have, you know, some dolls now that you can simulate very well the nose. So how to treat these patients, how to give them what they really want. First of all, train anatomy, and then train all the steps. Try to achieve, first of all, easy patients. What I mean easy patients, there is no easy rhinoplasties, but, you know, it's small defect that you can treat. And then you go forward and you go treat more difficult noses. I think this is the best choose for your treatment.
Thank you. Thank you, Professor Dr. Rami Fadul. Thank you for a nice contribution.
Thank you. Thank you.
Thank you all, my dear professors, and we are really eager to welcome you next year, maybe in person, maybe having you physically here with us. You will be more than welcome in our sessions. As you are always dear friends to the ICC, you've been very supportive and you always enriched our programs with your valuable scientific contributions that highlight the way for the young generations. Thank you very much and looking forward to meet you next year.
Thank you. Thank you. I would like to just tell something. Our hostel in São Paulo, Brazil, it's a Syrian Lebanese hostel, is one of the most important private hostels in our country. We are open to do fellowships and research fellowships or observer fellowships for all of you. Just come and we are happy to host you.
Thank you. Looking forward to meet you. Thank you. And now we close our scientific session. Thank you all for your attendance, and thank you, my dear professors and colleagues.
Thank you. Thank you, Fadel. Thank you, Dina.